Hey guys, Dr. Joshua Herzog here with OrthoVirginia. I do orthopedic spine south of the river, mostly at Westchester, also down at Prince George. Thanks for having me on today. I really appreciate the opportunity to talk about something new for me and newer to spine surgery on the global market is this endoscopic spine. And so it's we're going to go over a few different options that kind of outline it. I'm going to give you some case examples. I'm going to show you some pictures of kind of how we do it. And then of course, we're going to take some questions. But so when we look through this, we have some disclosures here, none of which are really pertinent to endoscopic spine. So we're going to talk about the anatomy of the spine. We're going to talk about what endoscopic spine is, why we kind of use it. We're going to talk about some tools that we can use endoscopically, and then I'm going to show you some case examples, and then we're going to wrap it up. So hopefully less than 30 minutes here today. So in general, endoscopic spine just means that we're using a small camera or what's called a scope to do some work inside or around the spinal canal. And, endoscopy has been around for a long time. The general surgeons and the urologists and the OB-GYN doctors have been using it in the tummy or the abdomen for a long time. And of course, orthopedic surgeons have been using it in the joints. We call that arthroscopy for a long time. And it's a very similar approach. We're taking a camera or a scope with a tube and then using that camera to see, and then possibly doing some work around that joint or space to make something better. And so these are some pictures of spine endoscopic approaches. And so the top three are what we're really going to focus on today: the medial branch transection, the intralaminar decompression, and then the transforaminal decompression or far lateral decompression. The bottom three, which are posterior cervical foraminotomy, the cervical unilateral decompression, and then thoracic transforaminal far lateral decompression, are definitely used for endoscopic spine and more advanced endoscopic spine type procedures. But we're going to talk about the top three in general. So the first thing I want to say is, why endoscopic spine? And the answer is that a couple of different reasons, but one of the big reasons is patients are asking for it. And, I think that the news is out there that endoscopic spine is available. And in general, people want something that is less invasive, that has a faster recovery, that can get the same outcomes. And so patients come in, they're asking for it. They're seeking out doctors that are doing it. And so patients are asking for it. And I think that that's, obvious by you being here today, trying to learn some more about it, but it is rather new to spine. It's been around for 25 years, but definitely kind of taking a quick trajectory over the past 5 to 7 years because of the advancements in the tools and the education that's now available. And we know that patients are willing to travel for it. They'll come, they'll see, they'll seek out surgeons that are capable of it. Training centers are setting up more and more training institutes to train on this technique. And I think that not only patients want it, but surgeons. And so surgeons don't want it just for their patient, but there's been a number of studies that show surgeons spine surgeons specifically would ask for endoscopic spine surgery on themselves, again, because it's less invasive, the risks tend to be less, and the recovery can be quicker. You can, again, end up with the same result. This is what we're talking about when we say results. So when we look at average length of stay for endoscopic spine surgery versus traditional surgery, there's been a number of studies that show with endoscopic spine, patients tend to have less pain from the incision because the incision can be magnitudes smaller. An incision for an endoscopic spine can be 4 or 5 millimeters large compared to a traditional decompression, which sometimes can be 2 or 3 inches long. Even a tubular decompression oftentimes it's an inch long, but the endoscopic spine is a much smaller tool. So it just has less dissection, less trauma to the skin. And because of that, patients tend to go home quicker. They tend to get up and move quicker. They tend to use less narcotics. And the complication rate, specifically the infection rate, is very low for endoscopic versus traditional. The readmission rate is less, again, because of the less amount of trauma that tends to be present with the small scope going down into the spinal canal or the region. And then the infections, of course, are lower. So again, little to post-op narcotics. The post-op recovery can be very quick, and this was well borne out in the arthroscopic shoulder literature back in the mid-90s when people made the switch from open to arthroscopic surgery, and now doing an open shoulder surgery is extremely rare. And so the same trend and trajectory, I think, is going to be there for spine to some levels. We're going to be switching a lot of these open surgeries to more endoscopic type approaches. So we know that there's, the beauty of the endoscopic spine is that you can imagine, where I normally have to kind of look down or make a larger incision to see a smaller amount or area. With the endoscopic spine, I can put a very slim tube into an area and then have a camera down inside that tube, and I can see that area of the anatomy kind of blown up on a big screen in 4K or 5K vision, where I can just see the details of the anatomy and work around it. And so what may have been more difficult to even appreciate in an open technique, the difference between scar tissue or nerves or blood vessels, becomes perhaps easier with the endoscopic because the visualization is just much, much, much more magnified. We know that, what the other thing that endoscopic spine can do is it can help with some of these back pain problems. And so, classically for back pain that's mediated or generated by the facets, we've done some blocks to the nerves that innervate those, and then we'll go in there and burn those nerves. That sometimes doesn't last for a long time. So the beauty of endoscopic spine is we can go in there and actually cut or remove that nerve that generates the pain to the facet joints on the back. And then it's a more long-lasting and more complete relief of that back pain. We're going to talk about that on the examples. And we know that it's cost-effective. There's been a number of studies that show because of the lower infection rate predominantly and the lower the quicker discharge from the hospital and lower hospital stays, the qualities, or and that's to say like the cost per improvement for these patients seems to be much improved. I like to talk about what endoscopic spine can do. Like, not only can it do the same procedure kind of in a smaller with a smaller incision, but it can do different procedures. And one of those examples is doing this medial branch transection. And so whereas we used to we still kind of go in and we'll burn the nerves. We can go in and find that nerve and see the nerve because, again, we're blowing it up. It's a very small nerve, 1 to 2 millimeters large, and we can see it and then sever that nerve or ligate that nerve. And that's just not possible necessarily with the naked eye. And so using the endoscope to do that. The other thing that it really opens up or helps with is revision cases. So again, differentiating scar tissue from recurring discs. In the thoracic spine, where it's harder to get to safely, specifically far lateral, you can more safely access that with a tube rather than doing a large open type decompression. So again, it kind of changes what we can do for these patients. It opens up a whole new world of possibilities. It just doesn't shorten or accelerate rehabilitation or recovery with the same surgery. It kind of changes and opens up. It's really some new tools that we can do for these patients to help care for a lot of their pain and their illness. So the anatomy of the spine, that there are different sections of the spine. It starts with the cervical, the thoracic, the lumbar, the sacral, and the coccyx. And each one of these different areas has some specific anatomy that's associated with it. And this is a classic lumbar vertebrae here, looking at the vertebral bodies as they come down. And the holes that you see there on the right side between the 1 and the 2 and the blue disc between there, that's the neural foramen. And so You can imagine that filled with a nerve, and that's what we're trying to kind of decompress in a lot of these situations. But knowing the bony anatomy kind of dictates and shows us where we need to dock, because we're going to use the x-rays to show us where to put those tubes. And then through the tube, once we start to see the visualization of the bone or the ligaments or the muscle or the nerves or the discs, then we kind of work systematically to get the nerve decompressed, or to get the area opened, or to get the nerve removed that's generating the pain. And so again, the vertebral bodies are key, kind of what they look like, and the facet joints, what they look like on the x-ray, so that we can dock and be in a proper location for where we think the pathology is coming from. These are the spaces that we're talking about. So this camera, or this tube, if you will, kind of needs to access the neural elements through very specific spaces. And so there on the left side, you can kind of see an x-ray. That's the interlaminar window is what we call that. And so you're going to be able to gain access through that blue circle into the spinal canal to do some work. And then in the middle picture, we have what's called Camden's triangle. That's out lateral to the side. That's where the nerves come out through the foramen. And that's where a lot of these disc herniations occur. And again, here we're going to be able to access the spinal canal through that foramen, or through the triangle underneath the arch. And so again, knowing this bony anatomy and knowing where the nerves and the discs lie is going to allow us to safely and properly treat a number of these disease pathologies. So I wanted to show you a picture of the endoscope. So this is a classic spine endoscope, but what's important is not necessarily what it looks like in your hand, but the portals. This is the very specific portal. So if you look on the top right side, that's kind of a cross section of that scope. And so you can see the working portal there is the whole circle is the cannula, but the working portal, that's to say, like what I'm passing instruments in and out of, is the green circle there. And it has this 4.3 millimeter working cannula, but then it has the two black dots. That's for egress and ingress of a fluid that's kind of coming in and out of the scope to kind of push the soft tissue open to make a little space to work. And then the blue dot is the camera, is the just camera that's present, so we can see exactly what we're working on with the portals. And so this is just the different types of cameras that we have, 15 or 30 degrees, different lengths for accessing different locations. Some locations require a deeper hole, some require less hole, or less length to get there. So I want to go through three specific examples. So the medial branch transection, classically patients with low back pain that we think is facet mediated. That's to say the hooks in the back of the spine are kind of generating the pain. Classically, we would do some diagnostic injections in or around that joint or on that nerve with some lidocaine to block that nerve and see if it kind of improves. And then if it improves, even temporarily, we can go in there and we classically go in there and burn the nerve. But that burning of the nerve is oftentimes done just with X-ray imaging. Now what we can do is we can do a block and then go in there and actually see that nerve, the medial branch that innervates the facet joint, which is a joint in the back that can be very painful. And so if we blocked it and it gets better, then we can go in there with the camera and see the nerve and then cut that nerve. That's called a medial branch transection. And so during that medial branch transection, these are some X-ray pictures here. So you would take your cannula, which is the metal device that you see, you would dock it there in the appropriate location on X-ray, and then you would dilate that up. And you can see there on the far right, that's the camera sitting on the facet or next to the facet, getting ready to kind of find that nerve. And so then this is what the camera actually looks like when you're in there. You can see on the left side, those are some scissor punches that are surrounding the nerve that's going in to innervate that facet joint. So you can appreciate how very small that nerve is. It's 1 to 2 millimeters. It's tiny, but of course it's blown up. So we're looking at it, but that nerve is running left to right between those scissors. And then once we cut or ligate that nerve, then it's no more. Oftentimes we'll cut or segment it out, take a piece, and then burn each edge so that it doesn't ever reunite or grow back. And that's the beauty of the endoscopy is, again, we sieve a nerve, we segment it, and then get the pain off there so it doesn't grow back and we don't have that back pain that's been plaguing us. So that's the medial branch transection. All in all, pretty simple procedure. You can do this with local or under sedation or general anesthesia. But the key is to find the nerve and get it so that it's no longer innervating that facet joint and generating the pain. So the next one is the interlaminar endoscopy, and this is kind of very similar to what we currently do, the microdiscectomy. And so the microdiscectomy, classically you would make a larger incision, go down there, open up the interlaminar window, take a piece of the bone or make a laminotomy or a window in the bone to better access the nerves, and you would push the nerve aside and then find the disc and get the piece of disc out that's pushing on the nerve, and you would do that all through an incision, sometimes 2 inches or 3 inches. And then we've kind of, with time, we've kind of shrunk that down to some tubes, and you have these tubes that you can use that kind of dilate, but they're still, an inch incision, and, oftentimes you have to use the microscope and you're looking through a tube. It's called a tubular microdiscectomy. And we've shrunk that down even further now to the 7mm cannula or endoscopy device to kind of do some of the similar work that we were doing with a more open procedure into a interlaminar endoscopy. So I'm going to show you some pictures of what that looks like. But this is that window I'm talking about on the left side. That blue circle there is the interlaminar window, and that's where we would normally access the disc herniation at the L5-S1 level, even with an open procedure or a tubular. But now we can put a small endoscope down there and find the disc, and then take that disc out that's pushing on the nerve and remove it. So that's what we're showing. That's the sequences there and the steps. So from the left, that's the window. We're going to use X-ray to kind of dock and put that cannula into or on the correct trajectory. And then we're going to remove some of the ligamentum flavum that needs to be removed. And then we're going to push the nerve aside and then get on the disc and take the disc out that's kind of pushing. And so that's the sequence that we're seeing. I'm going to show you some pictures through the actual camera that we're seeing. So those are the procedures that we kind of get through to get there. But the bottom line is safely open up that window, dock, sieve a nerve, push the nerve to the side, gently sweep that to the side, and then deliver or remove the disc herniation. So here, this is an MRI scan. So on the left side, that's a sagittal or a lateral. So we're looking at it from the side. To your left is the front, and then to your right is the back on the left picture of the MRI. And you can see that bulge, that blue arrow there is pointing to the disc herniation, and it is bulging. And then the yellow line there on the left actually represents the axial. So on the right MRI, that's an axial, that's a cross-section picture. The front of the tummy or the anterior side is up and the posterior side is down. But you can see this the black area in the center of the canal there that's herniated. It's on the left-hand side and it's pushing on the nerve. So that's a herniated disc at the L5-S1 level on the left side. It irritated the L5 or the S1 nerve root. That patient would have some numbness on the back of their foot or the bottom of their foot, and they would have some weakness in pulling or pushing their foot up and down. And so this is the X-ray. And so here on the right side, that's a lateral film, again, a side view of the back. And so at the bottom level, the 5-1 level, that disc, you can see how collapsed it is. That's because the disc is pushed out into the back. We don't see the disc, but we see the bone here. And the bone is definitely collapsing onto the disc. The disc is shortened in its height there. And so we've already seen the MRI, and that's showing the herniated disc. So if this patient had this for many months and or had some weakness, some significant pain, and tried some injections and or tried some therapy and not good, then we're going to go in there and get it. And again, classically, use a tube or do an open incision, but this endoscope now, we're going to go in there with the endoscope. So we're going to look for the bullseye. We're going to look for that interlaminar window on the X-ray. That's the white window there. And then we're going to dock that camera there. And we're going to put the camera into that area. We're going to kind of feel the click of the bone once we get down, we're gonna clean off the interlaminar window, which has the ligamentum flavum. It's a very thick, robust ligament that's down there. And we call that the trampoline because it doesn't feel like bone. It's kind of like feeling like a trampoline. And it's yellow. And again, the beauty of this endoscope is you can actually see the colors very clearly. And so once we get the edge of that bone identified, then we're gonna open that space up. And then this is the dura that we're gonna see next. So once we've opened up the hole in the ligamentum, then we're gonna see the dura, and we're gonna push our cannula further into that area to gently sweep that dura, which is containing the nerve root in that position. And then we're gonna retract it and protect it. Underneath that dura is gonna be the disc. And so once we identify the disc, then we're gonna start taking that out. We're gonna kind of open up some of the bony stenosis. So that's a kerrison, that's like a punch kerrison. Looks like one of those, almost like one of those, like a single hole punch we used to use in grade school, like to make a hole in the paper. It's very similar, but it can kind of punch and remove some of the bone that may be impinging on the nerve, but it also creates a small, little bit more area of a working area for the endoscope. And so once we identify that disc, then we're going to sequentially remove the disc and get it out. So the next example that I want to talk about is this transforaminal endoscopic spine surgery. And this is another example of something that really is new. It's it's a new tool is what I'm saying with the endoscope, and it's very hard to do without the endoscope because of the trajectory that you have to take aim at. So coming into the foramen from very far out lateral in the spine is just not possible with an open procedure. You'd have to make too large of an incision and go through too much muscle to get there. But with the endoscope, because it's thin and long, and you can make it, you can get to that position that you need to be. And so specifically for these transforaminal disc herniations, so those are disc herniations that happen outside into the foramen, pushing on that nerve. You can see in the picture there in the middle, that's the interlaminar, and then the transforaminal there is on the right side. And so if that nerve is getting pinched out there on the right side, then we're gonna take that trajectory, which is long and lateral, to access that and safely identify the anatomical structures and then get that piece of disc out that's pushing on the nerve. So this is that transforaminal approach. We've already seen this picture, but in short, we're trying to dock on the candidate's triangle. We're trying to find the pedicle and Wagner's arch, and then the exiting nerve root, the disc that's pushing there. And again, we can do some bony work. We can do some soft tissue work to remove the impingement on that exiting nerve root once we see it and identify it, and then safely protect it and get the items into the position that they need to be. And this, this transforaminal endoscopic discectomy is one of the original endoscopic spine procedures. It's really what it was kind of created for. It's very hard to do it without this endoscope. And so again, it's ideal for foraminal or extraforaminal disc herniations. It's very useful for thoracic disc herniations up higher in the spine, where we can gain access out lateral without doing a large dissection or a larger type surgery in the middle of the thoracic spine. And so, in summary, I think the endoscopic spine, again, it does two different things for us. It's, I think that it's taking some of the same procedures that we've always done in spine and making the incision smaller, and therefore decreasing the infection rate, accelerating the recovery, healing. I think that it's adding some new tools for us, specifically with the medial branch transection for those low back pain patients, and that specifically for the transforaminal far lateral disc herniation, being able to access those in a safe manner. And we know that patients and surgeons are both kind of keyed in and interesting. And we know that there's some improved outcomes, some accelerated rehab and recovery for these patients. So I'm happy to take some questions, but I appreciate you guys letting me talk about endoscopic spine and where we are. I think we've come a long way. We have a long ways to go, but it's definitely exciting, and it's a good time to be in spine surgery and part of the cutting edge and the advancement of where we need to be for our patients. Yeah, so we're going to answer some questions submitted earlier and questions submitted live. Not all questions we're going to get to all the questions because we're on a time crunch here. People have lunches to eat and so forth. So yeah, so it says, the first question is, can endoscopic spine surgery be used after a previous traditional spine surgery? And the answer is yes. It's one of my favorite procedures to use it on. So somebody's had a classic open or microdiscectomy or tubular discectomy, and they have a recurrent disc, or perhaps they have some scar tissue or some disc that was left behind. I think that the endoscopic spine tools are very good at differentiating those and being able to very slickly get in there without creating a lot more scar with an open procedure, and safely being able to differentiate between the scar and the recurrent disc and the nerve roots, which is what you want to do. So I do love to use it in some revision type surgeries, yes. So next question is, when discussing the interlaminar endoscopy, you said you would remove the disc. What keeps the area stable without a fusion? And so that's a great question. There are definitely some reasons to do a fusion, and most of the stability of the spine comes from the bony stability. And so usually if the plan is to do a fusion, we know that before we're going in to do said decompression or said spine surgery, because we know we have some sense that the spine is already unstable. You have a slip disc, or you have a scoliotic deformity, or I know that I'm going to have to do a wide decompression and create instability. And so those are all reasons to fuse the spine. The beauty of interlaminar endoscopy is that I have to remove even less bone to get to the ailment. And so in theory, you create even less instability by doing that. And so to answer your question, when removing this, what keeps the area stable? The answer is mostly bone, mostly the facet hooks in the back. And even though we take out the disc, in general, when we do a microstectomy, you're not taking out the entire disc that's up in the front. You're taking out the disc or the piece of disc that's irritating the nerve. And so again, with the endoscope, you can see that nerve. I can see how that nerve lays in its native canal by flipping the scope around and looking at it, how it lays on top of the disc. And then as I remove that disc and get it out of the way, I can actually see that nerve start to float on the back because I'm looking down the back. So the endoscope, again, very powerful tool to know that I don't have to either take too much disc or take too much bone to create some instability. So that's a great question. Thank you for that. Who is a good candidate for endoscopic spine surgery? Ooh, man, that's a good question. Well, I love, I think patients that are trying to get back to an active lifestyle, I think that's one example. I used to be very hesitant, like 20-year-old to have back surgery, in your 20s, like, oh, that's a boy. But the truth is the endoscopic tools, the invasiveness is so small. So now I'm if you've done some injections and you have a hot disc or you have a big disc, it's easy to pluck or remove or do a discectomy with that endoscope. So I think patients that want to get back to an active lifestyle, they don't want to have a lot of downtime. I think that soft tissue disc herniations are in general easier to pluck or take out than bony impingement, although you can do bony work with the endoscope. It just takes a little bit longer, but the soft tissue disc herniations compared to the bony overgrowth or osteophytes that can develop in the foramen as well, those are harder to remove with the endoscope. But I would say patients that want to get back, younger patients that want quicker recovery, less downtime, and with soft tissue disc herniations. Great question. Next question. Okay. Well, we've run out of time. That's you to come see me as a patient, or if you're one of my patients, you know that I talk a lot, so I ran out of time. So if you want to make an appointment, you can go to orthovirginia.com/appointments, and happy to see you. Love to see new patients or some recurring patients, really anybody. So I appreciate you guys just taking some time to tune in. Hopefully you learned about something with endoscopic spine. I'm looking forward to the next one. Thanks, everybody. Have a safe weekend. Godspeed.